Next slide. So we are hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, the Métis Charter Community of the Lower Mainland region, and especially after the information that we are getting over the last few weeks in terms of Indigenous lives lost. I think we all need to reflect on where we are, and how we relate to this land and the people on it. And all of you from around the province in your nephrology worlds need to acknowledge where you are and where and the peoples and the lands on which you sit. Next slide. So today's talk is something incredibly topical. I think it's top of mind for everybody. There's already a question in the chat. So on behalf of Transplant Nephrology, the University of BC Division of Nephrology, it's really great to welcome Allison Mah. She's a clinical assistant professor in the Division of Infectious Diseases here at University of British Columbia. She's completed her medical training in internal medicine at the University of Alberta, and then ID training at UBC, and went to University of Texas at MD Anderson Cancer Center for additional training in infectious complications of recipients of stem cell transplants. She's a practicing transplant infectious disease consultant at VGH and the training program director for ID. And she and her colleagues in infectious disease supply an amazing amount of information and support to the transplant patients across the province, actually. So Allison, really, it gives us great pleasure to welcome you to what I know we're all looking forward to understanding better, which is COVID vaccination in kidney transplant patients, some of which may apply to our other immunosuppressed patients and our dialysis patients. So Jag, I don't know if you wanted to add anything, but thanks, Allison.
Thanks, Allison.
Over to you.
All right, so thank you for that introduction. So as was noted, I will be speaking today about COVID vaccination in kidney transplant recipients. And I'm going to go over what we know so far, but also kind of areas of ongoing kind of research and outstanding questions. And this is an area that's continuously evolving. So even though, I updated my slides as of yesterday, I'm probably already out of date. So just acknowledging that. So these are my disclosures. Relevant is that none of these companies are involved with any of the currently available vaccine products. And then, as Dr. Levin also said, I would just like to acknowledge that I'm presenting today from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nations, and acknowledging that these are provincial rounds, that you're all coming to me from other traditional territories as well. So what I thought we would go for today, sorry, technical difficulties. Is reviewing the currently available vaccines here in Canada, and then discussing the evidence for these vaccines in the general population, as well as in the immunocompromised population, specifically talking about solid organ transplant recipients, including kidney transplant recipients. And then discuss what the guidance is around vaccination in this population, the practical advice that we can use from this evidence for patients and providers, and then talk about some of the areas of ongoing research in this area. So just a brief history of vaccines. So vaccines have been with us for the last several hundred years, starting in 1796 when Edward Jenner first used cowpox to inoculate people against smallpox. And the word vaccine actually comes from the Latin vacca, which means cow. And so you can see that as we march through history, vaccines have been with us kind of over those years and have been attributed with many of the gains in human life expectancy over that period of time. So by 1820, just 24 years after Jenner first trialed the cowpox vaccine, deaths from smallpox had halved. And so why do we care about vaccines? Well, vaccines work. So the cases, this is a schematic from Health Canada, but cases of various diseases that were extremely prevalent within human populations are shown on the left. And now in the current vaccine era, we can see that they're almost non-existent, and in some cases are non-existent. And vaccines also work in solid organ transplant recipients. So we know that despite, and we'll talk about kind of immunogenicity and immune responses, despite lower antibody responses to things like influenza vaccine, people who have had solid organ transplants still derive significant protection from vaccination. So during the H1N1 outbreak, people who were vaccinated against influenza had a nearly 25 times reduction in the rate of influenza. And vaccines also, just in addition to preventing actual infection, prevent bad outcomes from that infection. So vaccination in this population reduced pneumonia and ICU admissions. And so what are vaccines, and how do they affect the immune system, and how does the immunity and the immunosuppression that we have patients on affect this? So this is just a kind of silly schematic, but essentially I think of vaccines as fire drills for the immune system. So the antigen is exposed to your immune system, and you have an antigen presenting cell that is the fire alarm that kind of alerts the whole system to the presence of this antigen. Simultaneously, you can have B cells that are directly exposed to this antigen and can respond. And so that's kind of your first responder there. And then that alarm system from the antigen presenting cell goes and triggers helper T cells and cytotoxic T cells to be able to respond to that antigen. And that helper T cell coordinates this whole effort and then goes on to help develop memory for future exposures. And so this is a more scientific schematic showing this, just showing the antigen at the top, and then the antigen presenting cells, the B cells, the T cells. And the reason that it matters is that different vaccines can affect different pathways and affect the ability of us to respond and develop certain types of immune response. So polysaccharide vaccines are only able to kind of elicit this humoral side of the immune system, whereas protein conjugate vaccines or live attenuated vaccines are able to be processed by antigen presenting cells and then have more of a T cell dependent and cell mediated immune response. And so the new vaccines that we're going to talk about today, including the mRNA vaccine and the viral vector vaccines, have the ability to make protein or have us make proteins for them. And so that also stimulates the cell mediated immune side of our immune response. And this is just another schematic for the rationale for why we do vaccination. So the first time that people are exposed to an antigen, there's a relative lag for when it takes your immune system time to develop that immune response. And so that whole period of time of about a week, you can have unmitigated kind of replication of a virus and therefore disease. Whereas the second time that you're exposed, you have a much more rapid and robust immune response. And so this attenuates the ability of a virus or pathogen that you're exposed to from causing disease. And so what happens with our immunosuppressants? Well, we know that our immunosuppressants affect our T cells in various ways, as well as our lymphocytes in general. And so this takes out major kind of pathways within our immune response to vaccines, which explains why it's not kind of uncommon that we can see a blunted immune response to vaccines in our immunocompromised patients. So how do we actually evaluate whether vaccines work in these patients? Well, we have a few different ways to assess that. There's the primary outcome, and the thing that we actually care about the most, but is the hardest and takes the longest to actually develop information on, is the prevention of disease or reduction in disease severity. And then we have surrogate markers, which is what we're going to talk about, and I'm sure people will ask questions about, but that's looking at things like antibodies. So we can look at antibody titers or seroconversion, so a fourfold increase in those antibody titers. And we can also look at cell-mediated immune assays, which measures that kind of right side of the schematic, looking at your T cell response to an antigen. So we'll talk about what vaccines are available currently in Canada. And I wanted to just pause actually at this point, because I know everybody's really eager to talk about what type of vaccine people should get and how many vaccines and all of that. But I think we really actually need to acknowledge how amazing science is, and the fact that exactly 1 year and 1 day after the first case of COVID was identified in China, Health Canada had approved the first vaccine against SARS-CoV-2, which is extremely remarkable and not anywhere I thought we would be at this time in this stage of the pandemic. So what are the currently available COVID vaccines? Well, there's the incompetent viral vector vaccines. And these are both the Johnson & Johnson and the AstraZeneca products here in Canada. And so those are modified adenoviral vectors that deliver SARS-CoV-2 genes, which are there to encode the spike protein. And then that gene is transcribed into mRNA and then translated using your own cellular machinery within your deltoid muscle to create a spike protein. And then that spike protein is the antigen that is used to stimulate your immune response. Similarly, the mRNA vaccines deliver, again, a genetic message to your own cells. And this is through encapsulation in a lipid nanoparticle. And then your cells make that spike protein for your immune system to respond to. And so this is just a cartoon schematic. So you can see the adenoviral vector, which has the gene from the SARS-CoV-2 virus. And then that virus, the vector is brought within the host cell. That gene is transcribed into mRNA, and then that mRNA is translated into the spike protein. And then similarly, again, with the mRNA vaccines, you just go straight to an mRNA product as opposed to starting with the DNA gene, and then have that incorporate into the cell, and then have that translated into a spike protein. So what is the evidence within the kind of general population and in the studies? Well, it's pretty amazing. So for the viral vector vaccines at the top, there's slightly reduced vaccine efficacy when we talk about kind of after 2 weeks from completion of your series, whether you develop symptomatic COVID. But all of the vaccines are extremely good at preventing severe disease and hospitalization. And with the mRNA vaccines, which you can see at the bottom, there's both good vaccine efficacy as well as prevention of severe disease. And the important things for our patient population also are that none of these currently available vaccines contain a traditional adjuvant, which can be sometimes a concern or implicated as a potential cause of rejection or enhanced immune response. But we don't know, a caveat being that the lipid nanoparticle may have reactogenicity that we're not aware of. And then none of the currently available vaccines are live attenuated. So the viral vector vaccines are incompetent viruses that are not able to go on and replicate. They're really just a Trojan horse or a vehicle to deliver the genetic material. And so all of these vaccines are safe within immunocompromised populations. And then this is just a graph that people have probably seen. This one specifically is for the Pfizer product, the BNT162b2. And you can see just remarkable efficacy of this vaccine with kind of significant divergence of the curves and very few cases of COVID in the vaccinated cohort. And then what about in the real world? So now that vaccine campaigns are ongoing throughout much of at least kind of the Western world, we can see that in vaccinated populations, the vaccine maintains what we saw in the studies, highly effective at preventing SARS-CoV-2. And this data is mostly at the mRNA vaccine level, but also including the viral vector vaccine that AstraZeneca's product is. All right, so that's the general population. What about in the patient population that we specifically are here to talk about? So we talked about the different surrogates of kind of vaccine effectiveness. The most important thing that we want to know, of course, is whether or not it prevents disease acquisition and disease severity in our patients. One way that people try to figure that out is looking at immunogenicity. And so these are some small cohorts of solid organ transplant recipients. And you can see here on the left, in the organ transplant recipients as compared to healthy controls, which were healthcare workers, there was a reduced antibody response after vaccination series. And again, on the right here, it's actually reversed, but the solid organ transplant recipients are on the right of the graphs and the healthy controls are on the left. And again, you can see a reduced antibody response. And then what about cell-mediated immunity? So in this study, at least, which was a relatively small cohort, again, they saw a reduced cell-mediated immunity after vaccination series as compared to the healthy controls. And this was in comparison to looking at things like CMV and EBV, where they saw quite good cell-mediated immune response in both populations. And this is another study. So there's several of these kind of small cohort studies where the people have looked at their own local populations to see what their antibody responses are. And so this was a group out of Germany that looked at liver transplant recipients. And so they had 80 liver transplant recipients who were receiving a full course of vaccination and 25 healthy controls. And I should say that the majority of studies and what I'll talk about for the most part is the mRNA vaccines, because that's mostly the strategy that our patient populations are going to be exposed to and what most of the world and these studies are looking at in terms of kind of immunocompromised patients. But using again that BNT162b2 product, there was about a 47.5% antibody response in the liver transplant recipients and a 100% response in the healthy controls, and that's just shown here. Some of the predictors of vaccine failure are things that we see in the general population that can cause vaccine failure or failure at least to mount an antibody response. And so that was advanced age, reduced renal function, and then some of the medications that we give our patients to prevent rejection. So things like mycophenolate, high dose prednisone, and being on triple therapy. This is a study of lung transplant patients. And so here you can see in this graph, there were the lung transplant patients that were vaccinated and they had a significantly reduced or minimal, if any, response in terms of antibodies. And this is in comparison to people who actually developed COVID and had a lung transplant, and there was a much kind of more robust antibody response. And then healthy controls, which is a overall relatively small cohort, but again, you can see these differences. And they looked at the 12 lung transplant recipients who they had who were antibody negative and tested them for cell-mediated immune response. And there was a third of them who did develop some cell-mediated immune response. And so again, antibody response itself is not the whole picture. And then of the people who were kind of non-responders in terms of antibodies, 6% developed COVID in greater than 2-week period after their second dose, but all had a very mild illness, which we'll come back to. And then, as I already mentioned, the majority of people who had a natural COVID infection did develop antibody response. And one postulate is that their immunosuppression was held kind of during that illness, but also, of course, natural infection confers more immunity because there are more antigens and more significant exposure. And then this is the study that I think started getting people really talking about, well, do we need more doses and what's going on with our immunocompromised patients? But this was the study out of the Hopkins group looking at the immune response in their solid organ transplant recipients to either of the mRNA vaccines. And so in a cohort of 436 individuals, there were 17% who developed antibodies after their first dose. And the main things that were associated with that, again, that we saw in other studies were older age and the use of antimetabolites as their maintenance immunosuppression. And interestingly, especially given all that there is kind of in the media and people's perception about vaccine preference and people turning down certain vaccines for various reasons, the Moderna vaccine actually was associated with a greater antibody response as compared to the Pfizer vaccine. And this is actually not surprising necessarily because the Moderna vaccine actually has more of the mRNA and so greater ability to make antigen and therefore likely to stimulate the immune system. And then they looked at these patients again, or this cohort after their second dose, and out of 658, 54% developed antibodies after that second dose. And so this is just a slide from the ACIP, which is the Canadian kind of version of NACI. And they had a presentation just 2 days ago with slides publicly available. And as we can see from all of the kind of studies that we reviewed of different patient populations that have been looked at, organ transplant recipients do seem to have a lower antibody response. But what does that actually mean in terms of protection? Because what we actually care about is whether or not people develop COVID and whether they have severe outcomes from it. Whether you have antibodies or not is potentially neither here nor there. And so a Yale cohort looked at 459 of their fully vaccinated transplant recipients, and 0.65% developed breakthrough infection, or 3 out of that cohort, and all were mild and did not require hospitalization. A Florida cohort similarly looked at 623 of their patients, and again, they had a breakthrough rate of approximately 0.6% of their fully vaccinated transplant recipients. 3 out of the 4 did require hospitalization for supplemental oxygen, but there were no deaths. And then the Hopkins group, we don't have a denominator for, but they reported 14 cases of breakthrough infection, and half of them did require hospitalization, and there was 1 death. So still something, of course, that we are concerned about. And this is in comparison to the general population, looking at kind of all of the real world data where there's a breakthrough generally quite low at 0.001%. Now, Israel has done really an amazing job in terms of kind of vaccine acquisition and distribution, and also collecting data on their vaccine program. And so the real world effectiveness that's been assessed in Israel is really helpful for us. And they were able to look at a very large cohort of their kind of population of over 1 million people. And what they did is they looked at infection rates. And so it's a little bit of a different trial design, but they looked at infection rates from day 1 to 7 after their first dose versus infection rates after day 7 to 27 after their second dose. And the idea is that that day 1 to 7 is still an immune naive period. And so you should not have any protection during this period of time, but it allows for within kind of cohort control for some of the vaccine seeking behaviors and or vaccine avoidant behaviors that might cause those populations to diverge. And within this, they did have 27,000 individuals that were classified as immunosuppressed. They didn't actually give us a breakdown of how many of those people were solid organ transplant recipients, but this included stem cell transplant recipients, solid organ transplant, other immunosuppression, asplenia, advanced kidney disease, dialysis, and nephrotic syndrome. And so again, just like we saw on previous slides in the general population, there was extremely good vaccine effectiveness with 94%. This was reduced in the immunosuppressed population at 75%, but I would argue that that's still extremely good vaccine effectiveness in this population. And this is just a schematic again showing this. And so we can see that within our immunosuppressed population for SARS-CoV-2 infection, there was about a 70% protection with this black box, but prevention of symptomatic illness was 75%. And age, just like within kind of immune competent populations, was also a driver. And so older age groups did have a further reduction in that vaccine effectiveness. And then finally, what about safety? So for our transplant recipients, we of course are concerned about both the effectiveness of vaccines, but also any potential additive safety risks that there may come with the vaccine, particularly looking at things like rejection or enhanced kind of immune response or side effects. But really all of the studies, and this is just looking again at the Hopkins group who reported on their cohort, have shown either very mild side effects, kind of similar to the general population, or potentially slightly reduced side effects compared to the general population. And we'll talk about one kind of case of rejection, but otherwise there haven't been significant reports of rejection associated with the vaccine. And by now, hundreds of thousands of people, of course, have been vaccinated. So in general, because we're saying that, there's a reduction in these antibody responses, and as we saw, a reduction, although still quite good, vaccine effectiveness. So how can we try to improve this? Well, people have used in the past things like higher dose vaccines. And so we can see this in influenza and hepatitis B. And that's also what I was mentioning with potentially Moderna having a higher load of the mRNA and thus eliciting more of our immune response. You can use adjuvanted vaccines to help stimulate the immune system in a non-specific way to then respond to that antigen. You can give booster doses, and this can either be all comers within your population, or in situations where you actually know what a protective cutoff for serology is, you can use serology cutoffs to decide who needs to be revaccinated. And then you can use a prime and boost approach. And this is something similar to, say, what we do with pneumococcal, where we give a conjugated vaccine or a protein-based vaccine up front, followed by a polysaccharide vaccine to expand that immune repertoire. And this is potentially something that we could look at as more and more vaccine candidates for SARS-CoV-2 come online. And so the question that I know everybody's going to ask about, what about third doses in transplant patients? So this is something just in the last couple of weeks that's come up, because with those reduced antibody responses, people have been saying, well, what can we do about that? And so the Hopkins group, again, looked at 30 of their patients from their cohort who had either undetectable antibodies after their 2-dose mRNA series or low titer antibodies with 6 of those patients. And they administered a third dose. And what they did was a bit variable, and so it makes it pretty hard to extrapolate. But 15 patients received a third dose with the J&J, the Johnson & Johnson adenoviral vector vaccine. 5 received the same mRNA vaccine, so Pfizer or Moderna, and then 10 crossed the mRNA vaccines, so Pfizer-Moderna or Moderna-Pfizer. And they looked at antibody titers 14 days after that third dose. And of those 24 who had been antibody negative before that third dose, 67% remained negative. So there was a proportion that did mount an antibody response after that third dose, but it's important to know that this strategy doesn't necessarily improve antibody response in everybody, and we need to take that into consideration when we're thinking about what to do. The other thing that's really important is that one patient, and we don't know if this is specifically attributed to the third vaccine, but developed antibody-mediated rejection 7 days after that third dose. And so we may want to be stimulating the immune system to try to get those antibodies up, but to what end and at what costs? And then just 2 days ago, again, the French group released some information about third doses. So in France, they did choose to give third doses to their transplant recipients. And so they had a cohort of 101 solid organ transplant recipients, and they received 3 doses of the Pfizer product BNT162b2. The first vaccine series was according to the label with a 30-day gap between dose 1 and 2. And then the second dose, or the third dose, was given after 60 days. In terms of the antibody response, so after the first dose, it was quite low at 4%. After the second dose, it was 40%. And after the third dose, it was 68%. So a bit better than the Hopkins group, but still 32% who remained with undetectable antibody. And despite that an undetectable antibody, the entire cohort did not develop COVID, regardless of their antibody status. So again, going back to what does antibody status mean, as compared to what we ultimately want to know is what is the protection from the infection. And then within their cohort, there were no episodes of rejection. This is just a schematic from the letter that they submitted to New England. So again, showing that there was an increased antibody response after the third dose. So what does various organizations, or what do various organizations have to say about this? So this is again a slide from the recent ACIP presentation and their thoughts on what to do about booster doses. And so they felt that booster doses would only occur after there was evidence of a decline in vaccine effectiveness, and not purely tying this to antibody response. NACI gives a very general blanket statement about what we should do with immunocompromised patients, saying that we can vaccinate them. And then the American Society of Transplantation and the Canadian Society of Transplantation have a bit more kind of detailed information for our patients and our providers. So they do recommend, again, vaccination, as we all know, and that they do recommend, and same with the Canadian Society, that if possible, that we finish this vaccine series prior to transplant. And that they recommend continued kind of protective measures, and we'll talk about this a bit, regardless of vaccination status at this time. They also do not recommend checking antibody response to vaccine, and they don't recommend adjusting immunosuppression prior to vaccination. Similarly, the Canadian Society of Transplantation recommends the same things in terms of being able to vaccinate and trying ideally to vaccinate before transplantation. They recommend against a third dose of vaccine at this time, and also no additional doses even if you were transplanted in between kind of your first and second dose. And antibody response, again, is not recommended to be monitored, and infection control practices should be considered. So what do I think are practical kind of tips for patients and providers? What I think this all means, based on the evidence, is that current COVID vaccines and dosing schedules are safe in this patient population, and that protection from the vaccine, although the true vaccine effectiveness in this patient population is unknown, the Israel cohort gives us at least a bit of reassurance that it appears quite good. And because of this, people need to take into consideration what their own individual risk tolerance is. So people still need to be vigilant, but it really depends on what the risk situation is, where they are at, what the population level kind of infection rate is and vaccination rate is, and who they know and what type of a situation they're going to be in. And so people may continue to choose infection control measures such as masking in these high-risk situations, but they may not. And ultimately, what we can do to protect these patients is that as community infection rates go down and vaccination rates go up, this will increase safety for everybody. And so we'll just diverge a little bit and talk about herd immunity. Herd immunity, by definition, is the resistance to the spread of a contagious disease within a population due to a sufficiently high proportion of individuals being immune to the disease. And so we think about this when we talk about vaccinating families to provide that kind of ring around their immunocompromised patients. And we do this all the time with other vaccine preventable infections. And so it's important to protect the individuals who either cannot receive vaccines. So we think about this with some of our live attenuated vaccines, or who may have reduced protection, which conceivably is what we're seeing with these patients. And so vaccination is really essential for all healthcare workers, family and friends who are around these patients in order to protect them. And again, this is just one of my silly schematics, but if you look at these two different patient populations, the red people are all vaccinated against SARS-CoV-2 perhaps, and the blue population is unvaccinated. And within these populations, these light blue individuals are immunocompromised. And so if you have somebody who is infected, who then is introduced into these two cohorts, you can have transmission to the naive population, but you don't have transmission to the cohort that's vaccinated. And so then that transmission is propagated within the unvaccinated population, but our immunocompromised patient within this protective ring is happy because they're protected. And then the infection can continue to spread, and eventually, unfortunately, our immunocompromised patient gets exposed, and because they don't have that protection from the people around them, and perhaps either are naive in the case of things like our live attenuated vaccines, or have a reduced response, then they can get infected and can have worse outcomes than the general population, potentially. So what do we do now? So what are the outstanding questions? I think it still remains to be seen what is the effectiveness overall of these vaccines in the solid organ transplant recipients. And this is what we need to know, not specifically antibody response. And which vaccines therefore provide this greater protection? Are they the mRNA vaccines? Are they the viral vectors? Are they some of the newer vaccines coming online, like the adjuvanted protein conjugate vaccines? What are the immune correlates of protection? Do antibodies matter? Should we be measuring cell-mediated immunity? What is the antibody cutoff that we care about? Or are those correlates not helpful at all? And then should we be looking at alternative dosing strategies for solid organ transplant recipients, such as higher doses or specific products that we think are better, or this question of additional doses or third doses? And then another thing that's going to be important as we kind of continue on through the pandemic is figuring out how durable that immune response is within this patient population, as well as in the general population. And will there be boosters required, just like some of the other vaccines that we use within the general population? And then what are the long-term safety concerns in this patient population, I think is still unknown. So how are we going to answer some of these questions? Well, people are looking at, again, these third dose strategies, and there are different groups around the world looking at that. The group in Toronto is looking at a third dose of a Moderna COVID series, so 3 doses back-to-back of Moderna. And they're looking at 60 patients receiving this and 60 patients receiving a placebo, and looking at humoral and cellular immune responses, safety and rejection, and of course, effectiveness. And what are we doing? Well, we are part of a cohort study called the Prevent COVID study, and that's across Canada, across all of the major transplant centers. Dr. Sarah Belga, my colleague, is the UBC site lead, and we are looking at solid organ transplant recipients and stem cell transplant recipients who have received their vaccine as part of the usual schedule that's here in BC, and looking at their immune response, both humoral and cellular immune response after vaccination, and then following them for a year to look at really at what we care about the most, being that safety and effectiveness data. So for anybody who's interested in more information about that, or having patients enrolled, you can contact Gail here, who's our research coordinator. And people are eligible up until 6 weeks after their second dose. So I know that the second dose series has already started in people, but hopefully we might be able to catch a few people. So my take home points, and then I know that there will be some questions. So what do we know? Science is amazing. There are multiple COVID vaccines that are highly effective in the general population. And as noted before, this is all really within a year of first identifying this pathogen, which is unprecedented and amazing. These vaccines provide protection to solid organ transplant recipients through herd immunity and also individual level protection. These vaccines appear to be safe and generally well tolerated in this population. What we don't know and what we still need to figure out is ultimately what is the effectiveness in this population. So people do still need to take that into consideration and be cautious and use an individual risk assessment. We don't know what the immune correlates of protection are, and therefore antibody testing should not be performed because we don't know what that means and what to do with it. Optimal dosing strategies are unknown, and so additional doses of vaccine are not recommended at this time until some of those studies that I've alluded to provide further data. And then the effect of immunosuppression, which we didn't talk about too much, but is unknown. And so we would not recommend modulation of immunosuppression pre-vaccination, just weighing the kind of risks and benefits and the potential risk of rejection. So that's everything I have. And I know there's already some questions in the chat. So thank you for your time.
It's great. Science is great, and it is amazing how far we've come in the year, and how much we know and how much we don't know, as you alluded to. So thanks for that great talk. There are questions already. The first one you already answered, which is around the third dose. There is a question about people on MMF who are leukopenic and whether or not one should defer the vaccine until they recover, or any other tips in terms of leukopenias.
Yeah, so I mean, just looking at some of the data that we talked about, There did appear to be a reduced vaccine response, at least looking at the antibody response again, which for whatever that means. And so, and MMF was seen to be associated with that. And conceivably, as you say, Matt, that could be related to the leukopenia that we can see with those patients. I don't think that we know enough to specifically say that we should defer in these patients, although I do think that we are, initially, when the vaccine campaign still was rolling out and we were in the third wave, we just wanted to get everybody vaccinated because we wanted everybody protected. As rates come down in the community, the safety is significantly increased and the risk is reduced. And so we may want to start thinking about whether there are patient populations or situations where we want to try to optimize people's vaccine response. And so that might mean waiting a little bit longer after transplant before we vaccinate, particularly thinking about, say, stem cell transplant populations. We had vaccinated, or we had said we could vaccinate them much earlier than we normally vaccinate people against their usual vaccines post-transplant. And so we may want to think about trying to time things better while we're in a kind of safe window so that they can have more durable immunity.
Allison, if I could just piggyback on that real quickly. I think around so the leukopenia specifically, that when someone's in a leukopenic state is kind of a very specific scenario, but as you've alluded to, there may be other scenarios as well, right? So if we're waiting a month post induction therapy basically before we would do it, what's your current recommendation around treatment of acute rejection? Anytime we're kind of bolstering our immune suppressive regimens with patients, are we still saying about a month and give that period of time? I know we're still sorting it out, but just as we navigate it, what would...
Yeah, I think we don't know, and I think probably it needs to be a discussion with the patient. Because they, of course, bring their own values and preferences into that discussion. And, depending on the rejection treatment that they receive, particularly if they receive things like ATG or alemtuzumab, we know that they're going to have quite a profound immune suppression for probably out to 6 months. And so I would probably start, again, knowing that we're safer now, talking to patients about delaying until they're later, kind of more looking towards that 3 to 6 months so that they can get a better response from the vaccine. But discussing the pros and cons and the fact that they could get it potentially earlier unless we change our recommendations.
So I just wanted you to know that one of our patient partners actually commented that your quote unquote silly diagrams are excellent for patients and patient partners to help them understand. So I do think this is another area that we need to do better at, is having all the patients understand the concept of vaccination, because they are getting mixed messages, and the media is perhaps not always as clear as they could be. So that's a great point. Thank you, Dennis. About the UBC trial that's going on, can anybody sign up, or do they have to be referred by their physician?
Yeah, anybody can sign up. So we're doing it out of VGH. And so the contact information I put there, and I can put it, I guess, in the chat. Just let me pull up her email.
We can send it out with
okay, we can circulate it.
Yep.
But yeah, people, if people are interested, certainly, like we can't, just the way trials work, we can't actually directly contact people, but people can definitely contact us if they're interested. There is some ability to have people do some of the blood work kind of distributed throughout the province, but if possible, we're trying to have people come to VGH just because of some of the logistics of the blood work.
Yeah, and for the community that's on the call today, we are doing a very similar study in CKD, GN, and dialysis patients as well through the CTIF fund. So we'll have complementary data, and even maybe people who got their vaccine before their transplant and then after their transplant. So kind of interesting. There are some more questions. So again, from one of our patient partners, which I think is really important. Whoops, Daisy. Could you confirm that a vaccinated person who comes in contact with COVID is not likely to carry and pass the disease as opposed to a non-vaccinated person?
Right. So we know the answer is kind of yes and no. We know that being vaccinated against COVID definitely, as I kind of showed, reduces and significantly reduces your likelihood of developing disease. It also reduces your ability to carry the virus and to transmit it. There are cases where people are asymptomatic who have been vaccinated, and if they're swabbed, we can acquire the virus just through that swab. But the thought is that there's a very low risk. It's always a very small amount of virus that is kind of collected at that time, and there's a small, almost negligible risk of transmission at that time. So public health has actually said that double vaccinated people following exposures don't need to be isolated anymore.
And Allison, just to follow up on that, I guess that's the basis, I guess, for the recommendation, as you say, for creating that micro herd immunity around individuals who may not be as often affected, right? So for our patients, the advice I've been kind of given is make sure everyone in the household and the people you're interacting with are double vaccinated, and that are, you know, that's certainly going to enhance the protection. Is that a fair statement?
Absolutely.
And then again, there, I guess, reports of adverse reactions with vaccines in transplant patients. There's some reported with flu vaccines, et cetera. Are you aware of these? Funny, one would think that they would be mitigated in part because they're on immune suppressive agents, but reports to date.
The issue, so the difficulty with adverse reactions following immunization is that there is a baseline level that things will happen. So some people will develop rejection, and the ability to like just normally every day, certain people will develop rejection or have other adverse things like myocarditis, that type of thing. There is a baseline level within the population. And so then it becomes difficult sometimes to tease out what is actually attributable to the vaccine versus what is the baseline incidence within a population. And so I'm sure there are reports of kind of adverse things happening after vaccination, but looking at kind of the data, there does not appear to be a significant signal of any adverse effects within this patient population that differ from the general population. So it still tends to be kind of the usual things that you would expect, the sore arm, the feeling kind of flu, that type of a thing. So those are the main things. They're actually, as I think I mentioned a little bit, there seems to be a little bit less reactions, perhaps because of a bit of reduced kind of immunogenicity in this patient population.
Great. So Sean has his hand up. So Sean, go ahead.
Hi, Allison. Thanks for the great talk. I'm coming at this more from the glomerular disease point of view. It's interesting that in transplant, you haven't seen any evidence of rejection. In glomerular disease, there's been kind of an evolving series of mostly case reports of flares of glomerular disease that have occurred within a few weeks of being given an mRNA-based vaccine. And it really spans the whole spectrum of different diseases. So it doesn't seem to be disease specific. For some of these patients, I've actually prescribed prophylactic prednisone at a, let's say, moderate dose to prevent disease flares when they've had documented flares previously with either other vaccines or with their first dose of the mRNA-based vaccine. And I noticed on one of your slides that moderate dose prednisone was identified as a risk for vaccine non-response. So I'm wondering if you have any information on whether that was prednisone given in isolation, whether it was given with other therapies, what dose of prednisone constituted a risk threshold where that vaccine non-response risk increases, and am I actually doing more harm, than good, from a vaccine point of view, ignoring the disease point of view, which I don't expect you to comment on really.
Yeah, no, good question. I mean, I think it's a tough balance. I don't know enough to specifically comment on the risk of flares of GN, and of course, if somebody flares, then and you need to give them even higher dose steroids, then that potentially throws the whole immune status out the window as well. But I can share that paper with you. It was from a German cohort. It was in liver transplants. It was people on more than just prednisone because they were transplant recipients. Generally, people are not only on prednisone, although livers sometimes are immune tolerant. But they also showed that it was kind of triple therapy that was associated. The actual dose that they define as kind of high, moderate to high dose, I don't have off the top of my head, but I can send that paper to you.
Great, thank you.
There's also a question about whether or not we're going to use anti-spike antibody titers to inform immunity in the transplant population. There have been some one-off sporadic requests at the lab. Whether or not that will, I guess we need to figure out the risk and benefit of that kind of testing to inform third doses or whatever. But your thoughts on that?
Yeah, sorry, the recycling is coming behind me, so I'm sorry if I'm a little noisy. But so yes, I know people have had an antibody response. I don't think we know what to do with that yet. As I mentioned, with that French cohort, even the people who were non-responders, and arguably with a short follow-up, none of them developed COVID. So what we really care about is the vaccine effectiveness and whether you're protected. And I don't think that antibodies tell us that whole picture and could potentially just cause unnecessary kind of concern or potentially unnecessary or unwarranted kind of reassurance. And so we don't know. The other thing that we do need to be careful about, and I think that the lab has dealt with this, but some of the lab tests that were available, particularly from Life Labs, we're looking at antibody to the nucleocapsid, which is not something that would be measured in terms of vaccine immune response and would only tell us about natural infection. And so some people may have, depending on when they had antibodies tested, may have been falsely negative as well because of that just lab kind of issue.
Thanks.
I think there was a question about that we missed somewhere here about donor derived, like if you have a vaccinated and unvaccinated individual donating to a vaccinated or vice versa, are there any considerations there in terms of vaccine status of organ donors?
I don't think so. The most important thing is the recipient's immune status and vaccination status. I don't think that that's a particular thing. It's not like things like CMV, where there's been kind of thoughts about producing immunity and that kind of thing with CMV vaccines and that type of thing in donors. So I don't think it particularly matters. I also think that it's important, you know, everybody is eligible and should be offered and encouraged to get vaccinated, but we also can't use vaccination as something that people must do or that people are preferentially given access to just ethically in terms of especially things like living donation.
Allison, if I could just ask a comment and a question. There's no good answer to the questions. That's why I said maybe more of a comment. But, you know, I think, you know, moving forward, I guess the one comment is around protective measures, right? So now we're in this phase where the community transmission is decreasing. We're heading to a point where we're probably getting, hopefully, to a very low base rate of disease in the community. And so when we think about protective measures in our clinics, for example, where we're cohorting patients who may be suboptimally protected, there's a lot of thought being put into, well, should we retain masking, for instance, or, small cohorts, those kind of things to make sure that we can minimize that transmission among the people. And just, so is one of your thoughts on that type of approach. And then I guess the other one's a bit different, but around similar to what Daniel had asked around. So in terms of assessing durability as we move forward, given the limitations of antibody testing, so what are your thoughts on how you think that's going to unfold? Or is it still a big question mark?
Yeah, I think just like, so to your second point first, what ACIP has said, and also what we hope to be able to look at with the PREVENT kind of study, is what the durability of vaccine effectiveness is. I think we will look at antibody titers as well to see if that correlates, but I don't think we can say that at this time. But I think that is something that is being looked at, and that as we get that information, it will be helpful. We will also see within the immune competent population that information as well, because there are cohorts of that. And so that will definitely give us a signal, because if they start to lag off, then we'll need to be certainly more kind of thoughtful and cautious around transplant recipients. And then in terms of the question about kind of protective measures and that type of thing, as incidence goes down, I think, I don't know what the right answer is. I know that there is a lot of concern and angst, of course, and justifiably around COVID. It's dominated our life for the last 16 or 17 months. And there's a lot of fear associated with that. So I completely understand that. I do think we need to trust these vaccines, and eventually it's going to be hard. It causes me anxiety. It causes me anxiety to be around people without masks on, because we have just become conditioned to having a mask on and feeling unprotected if we aren't. But we are protected, and we have to know that the people around our transplant recipients are protected with, having been vaccinated, and that our transplant recipients do also have some degree of protection. So I think, I think it will be slow because people will be anxious, and I think that's justifiable. But I think as numbers continue, hopefully, to stay low, that we will gradually be able to open those things up and feel more confident.
Great. Thank you. Well, I want to congratulate you. Had, I think, the second highest attendance rate of any of the province-wide rounds this year. We're up to 90 at one point, which is pretty terrific on a Friday morning at 7:30. But more importantly, I think such timely and well presented, clear information that I think certainly for our patient partners on the call, and I would also speak for all the rest of the health professionals, a really much better understanding of vaccination in our vulnerable populations. As you know, BC was the only province to roll out a CEV, a clinically exceptionally vulnerable population vaccination strategy, to our knowledge, in a very organized way. And I think we're involved in a number of studies in these populations to see what the outcomes are, both epidemiologically, clinically, as well as from a biological perspective. So thank you for a really outstanding presentation. Thanks to everybody for their questions and their thoughtfulness. And have a fantastic summer, everybody, and stay safe. Thanks very much, Allison.
Thank you.